are going to explain the concept of OTIF, oblique thoracic interbody fusion. First, we have to understand how we do lumbar interbody fusion with the transcambine approach. Please have a close up now. Here we go at 45 degree, and I'm going to come here so you see it better, but I usually come from the left side. We go at 45 degree, I hit the pedicle of the level below. Here, let's put it this way, pedicle of the level below with this probe, and then I drop it in the cambine triangle that's here. That is because the nerve root is coming closer to the pedicle of the level above. By me going here and dropping here, I get access to cambine triangle. And then after we are done there, you see this is insulated all the way to the tip. The energy is 3 milliamp, and then we go to 4 milliamp. Once we are in cambine triangle, we drop it. Then we put a K-wire. Over the K-wire, we put a dilator. The dilator goes inside of the disc base, and then over the dilator, this working cannula goes in, and now we got access all the way from the skin to the disc base. So, and that is how OLIF is done. Now, we published our paper about 10 years ago regarding that procedure, and later on we started, if you may want to come over here, then have a close-up. We published a paper about direct thoracic interbody fusion. When we were doing cambine triangle surgery with the OLIF technique, we noticed sometimes we cannot get access to the cambine triangle. We noticed sometimes we were able to go transpsoas. Literally, nerve root comes here like this. Instead of giving posterior to the nerve root in cambine triangle, we would be going anterior to the nerve root through the transpsoas, or so-called prone lateral. Once we mastered these two techniques, OLIF and MIS DLIF, and we have published both papers about that, we started thinking about doing the direct approaches to the thoracic spine, especially T7, 8, anywhere actually below the scapula. What we would do, we would make a small incision here with the blunt, not with the probe, but with the blunt tube. We would poke through the pleura. We would literally walk the rib, go along and we would feel the head of the rib, and then drop, have a direct approach from the skin to the disc base. And good news is that literally once we put that tube in, one end of this tube is sealed by intercostal ligament and skin. The other one is sealed by actually the capsule of the disc. So in very few cases, about 15% of the cases, we would get a pneumothorax, but we would, in the same hole, we would put a small little drain, like a pigtail or something like that to counteract that. And successfully, we have done lots of these direct thoracic interbody fusions. The problem would become upper thoracic, and that where literally scapula is in your way. And especially for upper thoracic, all the way to T4, T5, but as well in the lower thoracic, where the pleura and the lung, they make it like a dive in. We start doing this procedure that we call MIS OTIF, MIS thoracic interbody fusion. The different there is those that in the MIS OTIF, our starting point is not at 45 degree like the OLIF, and is not direct like a direct thoracic interbody fusion, but we are about 60 degrees, so the entry to the actually skin is much closer to the midline than OLIF or MIS DLIF. Literally here, what we are trying to do, and that's important, whereas in OLIF, skin is very movable. In the OLIF and MIS DLIF, we have to be segmental. for example, for the lumbar spine, I do one incision and I put 3-4 cages sometimes in, but in OTIF and MIS DLIF, you have to be segmental. Each approach requires its own skin incision because we have to, here, for example, if I want to do MIS OTIF for T11, 12, the one that we did yesterday, I identify the rib, I go above the rib. Why above the rib? Because the vascular structure and the nerves are hiding just below it. So small incision, and then I go over the rib. I follow the rib, we call it running the rib, and I drop, I feel the head of the rib, and then I drop in the transcambine area. And that is exactly different between OTIF and MIS DLIF. In the MIS DLIF, like in MIS DTIF, we are anterior to the nerve root, we are laterally, but in the OTIF, we are truly transcambine, and once we are there, we put that in, we stimulate, and we have electrodes in the abdominal region that show us where we are. Then, like OLIF, we go poke through the capsule of the disc, dilate, and then put a working cannula. What is the advantage here? Number one, we are truly transcambine. We are avoiding entire pleural area. So after having done this probably around 30, 40 times, not a single pneumothorax has been encountered with OTIF. What is the disadvantage? The disadvantage is that we are truly oblique on a thoracic spine that has lower depth and lower sizes. So meaning that the sizes for the cage are going to be very limited, and as well, we do put the nerve root here at the regular risk, that which is right now seems to be about 5% initial nerve irritation, but that most of that get better. But this would be the approach. Now this is the different. The approach for the OTIF is like that. Approach for MIS DLIF is like that. Approach to OLIF is at 45 degree. MIS DLIF is like this. So, and if I was going to show them all in one thing, so this is OLIF, and can you hold this for me? This is OLIF, this is OTIF, and this is MIS DLIF or MIS DTIF, which is a direct lateral approach. These are the different in the approaches.
Is this in 35?
It's that's individually based on patient anatomy different, but it is this is more or less shows visualize all of that. Now please take a picture of that as well now. You can stop.